Hello, 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 everybody. It's your Uncle Jim, and we're back tonight on the Urban Kidney Network, and we're going to talk tonight with my transplant surgeon, Dr. William Goggins. Let me do a little introduction. Dr. William Goggins is a kidney transplant surgeon in Indianapolis, Indiana. He's affiliated with the University Health Medical Center. He received his medical degree from St. Louis University of Medicine. He trained in general surgery at the Medical College of Virginia, and he completed his transplant surgical fellowship at Massachusetts General Hospital. He has been in practice for over 20 years. He specializes in kidney transplant surgery for both adults and pediatric patients. The Indianapolis Star recently published an article. Dr. Goggins was recognized in 2018 for performing his 2000th transplant. From the Indianapolis Star, quote, "There's no doubt Goggins stands out, having notched more kidney transplants than some transplant programs as a whole. Last year, Lutheran General Hospital, Fort Wayne, did 13 transplants. St. Vincent's Hospital did about 50. Goggins might do 10 to 12 in a week." So, ladies and gentlemen, welcome my transplant surgeon and my good friend, Dr. William C. Goggins. Doc, how are you?
Hi, Jim. Doing pretty well. Thanks for inviting me on.
No worries, no worries. So tonight we're going to talk a little bit about transplant patients, the coronavirus, COVID-19, and we've got the right guy to ask questions to. So are you ready, Doc?
Sure, I sure am.
Okay. You are familiar with COVID-19 as it pertains to transplant patients?
Yes.
Okay. What are the symptoms for COVID-19? What is it that you look for?
Well, the big symptoms are fever, cough, malaise, and shortness of breath. Those are the four big symptoms. And I would say that probably fever is the biggest symptom. There was a study out of Wuhan earlier where they looked at the patients that were symptomatic, and 99% of them had fever. 70% of them had fatigue, and about 60% had a dry cough. And then there was a mixture of, muscle pains, some shortness of breath was only in about 31% of patients. So the biggest symptom was fever and fatigue.
Okay, so if you're a kidney transplant patient and you have those symptoms plus fever, you probably should contact your transplant coordinator?
100%. I think in the situation that we're in now, in a pandemic, and common things being common, right? So if you start having, if you're in a high-risk area, or in general, right? If you're having fever or malaise, or even now what we're hearing from our ID doctors is that there are many ways that people present with COVID. Some of them is just GI complaints, not feeling well, feeling sick, but the predominant thing is fever. So if you're having fever and other symptoms, not necessarily shortness of breath, being a transplant patient, immunosuppressed, you should be seen and probably tested, or at least have a closer look.
Okay. Are transplant recipients at a higher risk for the virus than, say, the general population?
Well, I would say that transplant recipients, because of their immunosuppression, are in higher risk for viral infections in general. So I would say that because they're at higher risk for viral infections, they would be at higher risk for contracting coronavirus. And the reason is the dominant immunosuppressant is tacrolimus or Prograf. And calcineurin blockers, and Prograf in particular, they block NK cells, which are a specific part of our immune system that actually fights viruses. So I tell people normally that if you get the common cold, for me, I may get sick for 3 or 4 days. Transplant patients in general will be sick for about a week, 10 days. And that's just because the main cells that fight viruses are taken out by the immune system. So that's why people are very concerned about transplant patients or immunosuppressed patients, because immunosuppressed patients are part of the higher risk group of people. So if you look at who's at high risk for having severe complications from the coronavirus, there are people over the age of 65, people that live in nursing homes or long-term care facilities, and people with high-risk conditions like chronic lung disease, heart disease. Morbidly obese people are at high risk with a BMI over 40. And then other things that affect the underlying immune system, like immunosuppression, liver disease, renal failure, stuff like that. So transplant patients are in a higher risk group.
Okay. And when we're talking about immunosuppressants, Doc, just so lay people understand, those medications keep my body from rejecting the transplanted kidney, from having to have it removed from my body. Is that a fair statement?
Yes. So it's a dual-edged sword. So you need immunosuppression to keep the kidney, or your body will reject it. And one of the things, if you have too much immunosuppression, or if you have an infection that requires your immune system, the fact that you need immunosuppression to keep your kidney hinders your body from fighting infection. And so, for example, like if we have patients that are infected, then we will cut back on the immune system, monitor them very closely, while cutting back on their tacrolimus and maybe just keeping them on steroids or something for a little bit till they clear the stuff. So it's a tricky thing. And in general, if people get sick with a bad pneumonia or like the flu in particular, you need to be watched really closely and managed very closely, because your immunosuppression has to be decreased. And that's what's keeping your kidney in you, the immunosuppression.
Right, because I remember when I was first transplanted, you started me out on 5 pills of TAC a day, and now I'm down to 1 in the morning and 1 in the evening. So there's a period of adjustment that goes on after you're transplanted. Is that a fair statement?
Yeah, 100%. So the biggest risk for having your immune system wake up and see the kidneys in the first six weeks to 3 months after the transplant. So you need your the strongest immunosuppression at that point. And after, if you have not had your immune system kick in and have rejection in the first, say, 3 months, your risk of having rejection goes down dramatically over the course of your lifetime. That's assuming that you're taking your medicine and doing everything that you're supposed to do. So that's why after you get 6 months, a year out, your immunosuppression levels can be run lower than you did at the time of transplant, because now the kidney's in and the immune system is pushed down and you don't need as much immunosuppression long term.
Very good, very good. Can you explain to us how the virus is transmitted? There's a lot of rumors out there. How exactly does one catch the virus?
So the virus is spread what's called person to person, right? So the virus is in the respiratory tract, or the lining of your body that goes from your mouth, your nose, all the way down your throat and into your lungs, and that's where it hangs out. And your body, in order to get air inside your body, you have to have a moist system so things flow easily. And so what happens is the virus is in that system, and when people cough or sneeze, the virus gets put into the air in these small little droplets from your breathing tract. And so it's spread person to person via what's called droplet transmission. So you might not even be able to see the droplets in the air, but the virus are in there. And that's why it's so important to make sure, one, you stay away from somebody that's coughing and sneezing and looks ill. And that's why that you have the 6 feet social distancing, so that you stay away from that area where the viral particles can be brought out of people's respiratory tract. You know, the other way that people can get it is, say somebody coughed or touched things and they put their hand on a railing or a box or something like that. Then you come by and you touch that box and get the virus on your hands. what I would tell you is the most important thing. There's two things that you can do to keep from getting the virus into your system. One is washing your hands, right? So what happens when you wash your hands? One, you're going to clean the area and keep debris and potentially virus off your hands. But two, the soap when you're washing with soap breaks down the layer of protection of the virus. So the layer of protection is like a fatty layer, and soap breaks that down. So the virus gets exposed and can be killed. And the biggest thing is, so how does the virus get into your body? If it's in these droplets and on the surface and stuff like that, well, it has to get into your body through your respiratory tract and the lining of your mouth and your lungs. So when people touch their face, I just wash my hands so I can do that. So if people touch their face or their nose or their eyes, right? So that's how the virus gets from your hand, from the surface to your hand and into your body. Your skin is very tight and it's a great barrier. So the virus isn't going to get through your skin. So even if you're touching it with your hand, it's not getting into your system. It's when your hand touches your nose or your mouth, that's how the virus gets into your system. So if you touch something, people are touching things all the time. Say you notice that some guy just went through and he touched that and he looks kind of sick and I just touched it. Oh, what am I going to do? Well, wash your hands. Go find a place quickly to wash your hands. Or if you have like an alcohol-based hand sanitizer, 60% alcohol, you do that as well. So as long as you keep your hands clean, which is very important, and you don't touch your face, you're at a much less risk of contracting the virus.
You know, since this has come up, Doc, I've just begun to realize how many times a day I actually touch my face. I really never thought about it before, but you know, it's more frequently than I care to admit. It happens often.
But if you're paying attention, it's like all the time. People do it all the time. I mean, I
All
do
the
it myself,
time.
and so you really have to watch. Nowadays, you really have to be very careful. And like I said, I just touched my face, but I literally just washed my hands.
Right, right. I did too before we started. Question from the audience: if there's a vaccine that's created for COVID-19, is that something that would be recommended for immune compromised people or people that have had a kidney transplant that are taking immunosuppressants, even if it's at its experimental stage?
Well, I think that what we would have to know is it safe? And I think initially, I don't think transplant patients would be exposed to that because you don't know how it's going to behave. But I think once it's deemed safe, I think that the transplant community will recommend that, just like we recommend the flu vaccine, just like we recommend other types of vaccines, shingles vaccine, stuff like that. So I think that once it's safe, if it's proven safe, even if it's proven safe early on, then I think that the transplant community will recommend that quickly.
Okay. You mentioned touching a railing. Does the virus linger for a period of time on certain surfaces?
Yeah,
Does
there was
it
a
linger
study.
more on some surfaces than others?
Yeah, there was a study from the NIH where, now this is not real life, it's sort of in ideal circumstances, but the virus can remain on plastic or stainless steel for up to 3 days, and can remain on cardboard for 24 hours. Now this is exclusive of wind, temperature, rain, and stuff like that. So in the ideal circumstances, this is a pretty hardy virus. And so that's why it's so important, if you're touching different surfaces, to make sure that you wash your hands and be super careful. And that's why people are suggesting, clean the surfaces with a bleach type solution, stuff like that, to try to keep everything as clean as possible. Some people are even suggesting that if you're getting like Amazon packages, to open the package up outside, bring the stuff inside, and just leave the package outside for 24 hours, and then go wash your hands quickly. And then in 24 hours, then dispose of the package. So I think that I would probably recommend that if you're in a high endemic area of COVID, then I would recommend
Same thing for the grocery store, for example?
Excuse me?
Same thing for the grocery store, the things you bring home from the grocery, you should be careful with that.
I think so too, because those are all cardboard and you don't know who's been touching things. And I've seen things on the internet that people are doing stupid things like trying to contaminate surfaces because they're just not good people. So I think that I would I would be very careful when you bring stuff home, and you can just leave them out. You bring stuff home, leave them out for 12, 24 hours, and then put them away, like on your counter, wash your hands, stuff like that. And I would just say that if you're in a really endemic area, that would be a safe thing to do.
Okay. When we talk about hand washing, a doctor, normally when I go to wash my hands, like let's say in the bathroom, I go in, I rub on a little soap, I rinse it off. It probably takes all about 5-10 seconds. What kind of hand washing are we really talking about? I'm looking for a little detail here.
Sure. Well, the CDC recommends that you wash your hands with warm soapy water for at least 20 seconds. So that's a good lathered up soap and a vigorous hand wash, and then cleaning it off. Now, the study that from the NIH, when they looked at the hand washing in particular, they only did it for 10 seconds, and it was very effective. But the CDC recommends 20 seconds.
20 seconds.
So I think if you can get at least 10 seconds, close to 20 seconds, you're going to be okay, particularly if you're warm soapy water. But most people, like you said, don't wash their hands for that long. We do when we're going into surgery. I mean, that's what we do. But when we're moving from patient to patient, we really have to pay attention and really focus on keeping our hands washed.
That includes in the dialysis lab too, right?
Yes.
Moving from patient to patient?
Yeah, 100%. Yeah.
You talked a little bit about touching your face. It's my understanding the virus is transplanted through your nose, through your mouth, through your eyes when you touch your face. Are those correct understandings?
Yeah, that's the biggest way. And some people think, well, why if I touch my eyes, why is that going to happen? Well, your tear ducts go from your eyes into your nose, right? So when you touch your eye, that's a mucous membrane or a moist membrane that keeps the system lubricated, right? So the virus can go in through there, through your tear duct into your nose and your respiratory tract. And then once it's in that, the virus must love that type of area of your body, and that's where it goes. That's where it really replicates, and it thrives in that area. So unless you really touch your nose or your mouth or your eye, the virus is going to have a hard time getting in your body unless someone coughs or the virus is aerosolized or put into small particles in the air that you end up breathing in.
Okay, you know your Uncle Jim. As a kidney advocate, every once in a while they ask me to get on an airplane and fly someplace. I've been to San Francisco. I've been to Washington, D.C. are a couple examples that come to mind real quick. Kansas City, Indianapolis. Are there travel restrictions for transplant recipients due to the virus?
Well, there's no travel restrictions per se for transplant recipients. But transplant recipients should follow the same travel restrictions now for the general population. And really, there's a lot of travel restrictions now about moving from different places and not having, if your travel is not 100% needed for whatever reason, you shouldn't be going. And I would even say for transplant patients, find another way to do it rather than in person. And if you really can stay away from high risk areas like airports and other places where a lot of people go, I would not recommend traveling at present at all for transplant patients.
So a lot of use of what we're doing now, like social media and communicating over the internet, is preferred to going to a large meeting, for example, like going to Washington, D.C. for the National Kidney Foundation Summit, where there'll be, a couple hundred people.
Yeah, at least now almost everybody is going to virtual meetings. We don't have any meetings more than 4 people where we are. Everything's gone virtual now, which is kind of, it has some issues, but it's kind of nice that you don't have to, you can still get things done, but you don't have to have a risk from that.
Our friend Angela is asking, will heat kill the virus?
Just heat per se? I would think if it's hot enough, like in the oven, you're going to kill it. But just your ambient temperature, I don't think it's going to kill the virus. That's why it stays out on things. There's some suggestion that this might end up being a seasonal type virus that is affected by sort of like the regular flu or regular cold season where it may go down in this summer and then come back in the fall. So if that's what she means by heat, then it very well might likely be affected by heat in that sense. But I think we're still trying to figure this virus out to see what exactly it's going to do. The southern hemisphere is in the summer, and they're being infected just as much as we are up here. So the people are a little bit concerned that it might not be seasonable, but I don't think we know yet.
Okay. Is it fair for me to say that we should avoid any non-essential travel? Would that be a fair statement?
Yeah, I would say so, 100%.
Okay. And right now in my state, in the state of Indiana, our state, Doc, we're on a stay-at-home order. Basically, we can go to the grocery store, we can go to the drugstore, but otherwise the governor has basically asked us to stay home. Is that a fair statement?
Yes. Yeah. And that's the best way to keep the virus from spreading. Mitigation, social isolation is the best way to keep the virus from spreading. One of the things that I think that we have that's good for us being in the Midwest and Indiana compared to New York or some East Coast cities is we have social isolation in general. People don't live on top of each other, and we don't have a subway system where 10 million people are using in a week, and so I think that and everybody's driving to work. Everybody's crazy saying, we need all this public transportation, but we're kind of lucky that we don't have it, because I think that's what's going to keep us from having a big spike like New York City. I mean, New York City is just sort of the perfect place for this to go crazy. I mean, if you think about it, it's just amazing. That's why I think a lot of the Midwest, Chicago's probably going to have some trouble because of the population density, but in your cities, Indianapolis has the most cases in Indiana, but that's just where a lot of people are. But if you're living in Lafayette or Fort Wayne, or places that aren't as big and don't have as much, or even if you're living out in more rural Indiana, you're fine.
Okay. Let's suppose, Doc, that a family has gone out and they've just returned from an area with high COVID-19. What steps should be taken to prevent the virus from spreading through the family?
Well, the one thing that is recommended if anybody's traveling from an area that has a high penetrance of COVID-19, if you go to another area, you should basically self-quarantine for 14 days. Most people will start to have symptoms between 3 and 5 days, but it takes a total of about 14 days before you're sure. And so if you've come from that area and now you're self-quarantining because you're at high risk, because you've been in one of those areas, if you start to have a fever or cough or other symptoms, that's when you need to seek medical attention. Call your coordinator, call your doctor, get tested. But in general, if you're coming from a high risk area, if you're asymptomatic, then you basically just have to do like everybody else in self-quarantine, just make sure you're okay.
Okay. What do we do if avoiding contact is not possible? We come from a high area. We're stuck in one place as a family. What do we do to avoid that contact? How do we avoid the problem?
Well, I think that you have to take the basic strategies of trying to stay 6 feet away from people. Try to recognize who is sick around you. If you're going out, make sure you have a mask on, because that's another layer of protection. If someone inadvertently comes up to you and someone coughs near you, what I would do is I would immediately go try to find a place where I can wash my hands and my face. And if I didn't, then I would just try to make sure I had some Perel or something on that I could just wipe my hands as quickly as possible. But you're just going to have, if you're in an area, you're just going to have to, if you can't stay in your house, and you, like what I tell a lot of my patients, if you're in a high risk area, okay, now you're going to have to talk to your family. You're going to have to talk to your other caregivers to come up with a strategy to help you. How are you going to get groceries? How are you going to get your medicines? Can you have people help you with that so you don't have to put yourself at risk? My mother-in-law lives on Long Island, okay, in one of the top 10 counties that everybody's dying in. And I tell her, don't leave your room. Stay in your room and have your kids bring you stuff, because she's 85, and if she gets it, she's a goner. So you just have to be really, really careful, particularly if you're in a high-risk area.
Okay. Should a transplant recipient wear a mask in public places? Like, let's say you go out to the grocery store or the drugstore. And if so, what kind of mask are we talking about?
Well, I think now, particularly if you're in a high-risk area, you should be wearing a mask, and really just a regular surgical mask is good. Now, if you can't, bandanas and the cloth-made masks are pretty good. They're not as good as a surgical mask, but they're pretty close. You don't need one of these N95 respirator masks. In the hospital, now everybody's wearing just a regular surgical mask when you're walking around and talking to people. The only people that have to wear those really important masks, the N95 masks, which put the small particles out, are people that, like anesthesiologists, if someone's having a bad problem, they have to put a breathing tube in, or people that are dealing with patients coming out of their body and aerosolizing, getting up in the air. Those are the people that need those masks. So the regular masks that you see people walking around with, surgical masks, are just another layer that help to keep an inadvertent particle from hitting you. And so I think if you're in a high risk area, I tell my patients, get a mask, and I would wear a mask around. Now, if you're living in a real rural area and they don't have any cases or one case of coronavirus in your county, and I don't think you have to be walking around with a mask. You just have to be on guard and careful. The Johns Hopkins website for coronavirus now has the country broken down by counties. And you can actually click on your county and see how many people tested positive for it, and how many people have it. So you can go wherever county you are, you can click right on it. For example, like I live in Boone County, which is just northwest of Indianapolis. We have had 4 patients in Boone County with coronavirus. Marion County, where I work, has 228, or even higher now. So if you're walking around in Boone County or in Lebanon or somewhere like that, you don't have as high a risk because there's not many people with it. So I don't think you necessarily have to wear a mask when you're walking outside. But if you're going to go to an area where there's more people, then you may want to consider wearing a risk. Now, my patients that are in downtown Indianapolis, I'm saying wear a mask all the time.
Okay. When we're talking about masks, I've seen people pushing these N95 masks as opposed to just a cloth surgical mask. Can you comment on that for us?
Yeah, I think that those are very difficult masks to get a hold of. And most places that have extra masks are sending them to the hospitals for the physicians that are the highest risk of getting coronavirus. Now, I don't know if you've heard, but there are many physicians and nurses that are on the front lines taking care of these patients that have gotten ill and even died of coronavirus. And I think that what happens is when the patients first come in, people don't know, and they don't have the correct personal protective equipment, and then they get infected. Once you're in a situation where you know where your high risk is, and say you're in the ICU, someone's on a ventilator, or they're going to be put into have a ventilator, intubated and put on a ventilator, that's when they need those high N95 masks. In general, otherwise you don't. And with the hospital, they're not recommending that anybody else has those, and save those for people at high risk.
Okay, we had a couple questions that came in from the audience. Let's suppose that I have an appointment to go to my blood draw every month or every other month. So my post-transplant doc can check my levels. At this period in time, is it a good idea to go down to, let's say, IU Health in Indianapolis just for a blood draw, or should we wait until later? What's your opinion?
I would say if you can go to a local lab to get your blood drawn, it's probably safer. We have patients coming in all the time to University Hospital. Our hospital in the system is going to be the last place that coronavirus victims come, because we have so many transplant patients and cancer patients. And so our hospital, there's nobody in the hospital currently with coronavirus, so it's super safe for people coming to get their blood drawn. Now, if we end up having an influx of patients like crazy in the next 2 weeks, and the hospital is going to have to take those patients as well, then it's a different story. But I think that if you don't necessarily have to go to high endemic areas where there are a lot of people and you can get your labs done locally, we're doing a lot of telemedicine, a lot of remote labs and stuff like that now to decrease people's risks.
Okay, Doc, another question. Let's suppose that a transplant recipient is diagnosed with COVID-19 and they're in the hospital. How are they being treated? What is it that you try to do for those patients?
So there's a different strategies of treatment for people. So if you're in the hospital, then by definition, your oxygen saturations are lower than you could be followed at home. So you're at a higher risk group. So there are different treatment strategies that are starting to be used for those patients. Some of it has to do with giving the patients hydrochloroquine, Plaquenil, basically the new drug. And also there's when people get more ill, the transplant patients for this, their symptoms are going to be treated sort of like the other patients, depending on how sick they are. But the hydrochloroquine and azithromycin are going to be used for people that are getting sicker. Now, some of the experimental drugs are starting to be used for really sick people, and we're trying to set up our own adoptive transfer so that where people who have recovered have antibodies to try to harness their antibodies and give it to really sick people. We're establishing that now. We're trying to go with Mount Sinai in New York. We may have to have our own IRB, but if we have patients that have recovered and they have antibodies, sort of like the same thing they did with the swine flu in 1918 to try to help people. So there's a lot of different things, but I think in general, if people are sick enough to be in the hospital, they're going to be on one of the drugs that they're talking about, hydrochloroquine.
Doc, one of our audience members, is race a factor with kidney transplant patients and COVID-19? He's indicating that in Milwaukee, Wisconsin, 52% of the COVID-19 people are Afro-American. Does that indicate that race is or is not a factor in the spreading of the disease?
I haven't seen anything that says race is a factor. Some people are concerned that men are more at risk for COVID-19. There's some data to suggest that blood group A is more at risk for COVID-19, but I haven't seen anything about race being a problem. It might be the fact that in Milwaukee, where someone got, if it's from a group in an inner city or something like that, that they may have all just been in the wrong place at the wrong time. I don't know. Certainly, I think if you're in large population areas like New York that has 10,000 patients that have been infected, it'd be easy to see. But I don't think that I think that this virus doesn't care who you are, what you look like. It's going to go after you.
Is age a factor? I've read some things where it said younger people, children are not as readily to contract it as older people. And I've read things that were contrary to that they're discovering that age doesn't make any difference. What are your thoughts?
Well, what the data seems to suggest that if you're older, above 60, in particular if you're over 80, you're at the highest risk of dying from this virus. And last week, the average age of people dying in Italy was like 84 years old. So I don't think even as of now, there's been a death under the age of 10. I think there's only been one death in the entire world under the age of 20. There was a report out of LA that they said there was a second person, but then yesterday they said it was sepsis and it was not related to coronavirus. So if you're under 30, people get infected. The vast majority of them are asymptomatic, but they can shed virus and infect other people. As you get older, the immune system isn't as robust and you can get more infected. So after you get over 50, between 55 and 65, your risk of dying goes up from less than 1% to 1 to 1.4%. Over 60 to 74, it's like 3%. Over 70 is like 7 to 10%. And over 80 is the highest group. So that's why, it goes right through nursing homes and stuff like that. And a lot of people die.
Sure. Doc, question from the audience. I remember right after I was transplanted transplanted, I frequently had to go back to the transplant clinic for treatment. I think I was doing infusions at that time, for example. What if you have to go back for your transplant clinic? Are there issues with that because of the virus? Is that an appointment you should keep, like your dialysis appointment? How would you characterize it?
Yeah, I think if you're in the early month or two after transplant, it's super important to go to be seen to make sure you don't have any complications and your immunosuppression is being checked all the time. We are very early, like within the first 6 weeks or so, trying to transfer people to virtual clinics where they're getting their labs and they're being able to be seen, not in person, but they're able to be seen and talked to by a physician. And then if there's a problem, then we can have them come to be actually physically seen. So if they have virtual clinics, that's important to do that. If you're really early after transplant, then going and being seen physically is important. But after you get past the first few weeks to a month where your overall risks from a surgical complication drop dramatically, and now you're just dealing with immunosuppression and stuff, then I think virtual clinics are a better way to go. But definitely you have to have your follow-up in one way or another, and you have to get your labs done, or otherwise you run the risk of losing your kidney.
Right, because I had an appointment for a blood draw last Friday, and Dr. Debbie, my post-transplant doctor, wanted me to go see a PCP down there, and I wrote him, and I wrote my transplant coordinator, Moni, before I went down, and they recommended I not come, that I reschedule it. So I'm rescheduled for July to go back.
I think if you're 5, 6, 7 years out, or 10 years out, then and you're coming for sort of your annual visit or your 6-month visit, I think at present it'd probably be better to just get your labs and then change your visit unless you're having a problem. I think it keeps you from going into the hospital area where there might be some people that are sick. So I think that's probably a good course of action to just change things up for a little bit until this hopefully this blows over in a few weeks to a few months. And then it's a lot safer.
Okay, let's talk about for a minute the proper way of sneezing. I've been told that when you sneeze, you either sneeze into a tissue, which you dispose of immediately, or you sneeze into the crook of your arm or your elbow like this. Is that a fair statement, Doc?
That's exactly what the CDC recommends. So the CDC recommends that you sneeze into a tissue if you have it, and then immediately dispose of it and wash your hands, or sneeze into the upper part of your arm like you showed.
Okay. If I suspected that I had the virus, if I had a fever, if I had shortness of breath, if I was having respiratory issues, how do I get tested to see if or if not I have the virus? How does that work?
So if you're having symptoms, you should contact your transplant coordinator or your physician. There's actually now a new Apple app that just came out today about COVID symptoms, and you punch in your symptoms and it tells you if you need to be seen and may even tell you where to go. IU Health has a virtual app that you punch in your symptoms. You can press COVID, and then it can even arrange for you where to get tested. But in general, if you contact your coordinator or your doctor, one of the things or the emergency room, but if you're going to go see a physician or the emergency room, you have to call ahead and tell them, hey, listen, I think I got COVID, or I'm concerned that I have something. Even the emergency room, that's one, they can protect themselves. So if you do have it and they're not protected, if they don't have their personal protective equipment on, they could get infected. So by you giving them a heads up, lets them, one, protect themselves, and two, you'll be ushered into a safer area where people are being contained and being tested away from the general population, where there are negative pressure, airflow measures being taken care of, and people have protective equipment. So I think the key is if you're having symptoms, contact your physician. And if you're going to go to the emergency room, you got to let them know that you think you may have it, just so that people can be protected and then get you to the right spot so that you're not, so one, you can get tested, and two, you're not going to risk infecting someone else.
Okay. Doc, I live in Hammond, Indiana. I'm maybe 20 minutes out of Chicago. I live way northwest near Lake Michigan. How can I prepare for an outbreak of COVID-19 in my area? What are the steps that I should take, if any?
Well, one of the things that we're telling patients is that, for example, okay, so you have to be prepared to be, if the quarantine gets even more stringent, right? So you have to make sure that if you can't go out, you have people that can help you to get groceries, to get food and water. We're recommending that our patients have an extra 2 weeks of medications on hand. We don't think that there's going to be a disruption of getting medications. There doesn't seem to be that problem. However, if there is, we're telling people they should be safe and keep 2 weeks. So you should talk to your transplant coordinator about being able to get that. The other thing is, if you have to go out and get your meds, if you don't have delivery from a pharmacy that delivers, then if your pharmacy has a drive-up, I'd use the drive-through to get your meds. You're in your car, you're staying away from people. You don't have to go in.
Mail order?
That's what. If you have mail order, that's a great way. Once again, you may want to just make sure the box doesn't have anything on it. Keep it outside, away from you for 24 hours or something like that, and then or disinfect it or something.
Question from the audience, and I can relate because some people have seasonal allergies. I have seasonal allergies. How do you tell the difference between your seasonal allergies and the COVID-19 virus? When is the indicator that you should go get tested?
I think the difference is I have seasonal allergies as well, and I can sort of tell that, oh, this is sort of I get a stuffy nose, I get a little low-grade fever, I just sort of feel off. If you're thinking to yourself, wow, this doesn't feel like my seasonal allergies. This is a different type of cough, or this feels, I feel a lot more tired than I normally do, or this is a lot higher than my fever normally is, or I just don't feel right. You're going to have a sense that it's not your seasonal allergies. You've had the seasonal allergies so long, you're taking, whatever you normally take for it. I take Sudafed if I have it, or ibuprofen because I have good kidneys. But if you all of a sudden say, you know what, this just doesn't feel right to me, or I'm coughing a lot more than I normally would, and certainly if you're having shortness of breath and a fever, those are things that are going to trigger you to seek help sort of immediately. But if you just sort of have a runny nose really isn't that big of a symptom for COVID. Or stuffiness. It's more of the fever malaise cough, not just like, oh god, pollen's coming up, so it's
a dry cough or a productive cough.
Well, I think that it leads to more of a productive cough. The Wuhan study said 39% of the dry cough, but most people, I think, are going to end up, if they're getting bad, they're going to end up starting to bring some stuff up. But most of it starts as sort of a dry cough. But if your fever is a little bit more, I think the malaise is going to be a much more striking feature than just seasonal allergies.
Okay. I'm waiting for a transplant, and I'm wondering, if I'm transplanted, can I get COVID-19 from my donor? And as far as transplants are concerned, can you tell us what's going on at IU? We were talking about this a little bit before the broadcast. I want to let our audience in on this. Sure. When are you doing transplants? When are you not doing transplants? Can I get the virus from my donor? How do you protect me from that sort of thing? Can you help us out with that?
Sure. So at present, we don't think that the virus gets into the bloodstream. So that's why you can donate blood and the blood supply is safe. So if it's not getting into the bloodstream, it shouldn't get into the organs except for maybe for the lungs. But I think at present, without knowing that for sure, if a donor tested positive for COVID, I don't think that anybody would use their organs at present. What we're doing is we are not doing living donor kidney transplants at present. And that's because I think the overall, we feel as a program that the overall risk in this climate of the pandemic, the risk of getting the virus is higher than waiting a couple weeks to a month before you get your living donor transplant. So what we're doing is we're still doing deceased donor transplants at present, and we're specifically looking to transplant patients that are at a higher risk of dying on dialysis than the risk of the virus. So we'll transplant patients but there has to be certain conditions. One, the donor has to be COVID negative, and we're testing all the donors, and the donor can't have had an exposure or anything that would make you think that they had a COVID infection. And then our recipients, we're looking at recipients currently that are way down the list. I've done 4 transplants this week, and the patients were 80, 90, 110th on the list. So they're going to be waiting 3-4 years for a kidney. And so, and we're looking for patients that that aren't over 60, right? So they're in a lower risk group and aren't high risk. So, but are more at risk of being on dialysis than the COVID. And those are the patients that we're transplanting. Now, the recipients can't have a sick contact, they can't have a fever, they can't have a cough. And when they come into the hospital, we do a CT scan of their chest to make sure everything looks okay. And if that's the case, and they're willing to self-quarantine after the transplant, then we're transplanting currently. Now, in another week, 10 days, if this gets really bad and there are just a bunch of COVID patients all in our hospital system, and now people are really sick, then we're going to end up suspending transplant for a while, because I don't think we can take the limited resources from the seriously ill, the critically ill people. So we'll end up having to put transplant on hold until it passes. But at present, our hospital doesn't have any COVID, and we're still able to transplant people. We're just not going to do really high risk people. We do a lot of high risk people, but we're not going to do any of the high risk people currently, because if they end up in an ICU bed, now they're going to take a potential ICU bed from somebody that if it gets bad. So that's what we're doing currently.
Doc, I just started a page on Facebook called Kidneys and the Coronavirus. And I'm wondering, when I post, where do I get the best information to share with my kidney friends? Where is the best place to get information about the virus?
I think the best place currently is if you go to www.cdc.gov and /coronavirus, or you just Google CDC and coronavirus. They have so much information. Now, if you're just interested in what's going on with the coronavirus, where it is, the Johns Hopkins Institute has the coronavirus map, and that's where you can go into and you can look at your county and see where how many infections are in your county, how many people have been tested, if anybody passed in that. But the CDC really has an incredible amount of information for people about the virus, what to do, how to take care of yourself. It's a great tool.
Okay, Doc, the IU Health, the transplant people, they sent me out a note about things to do, for kidney transplant patients. And one thing I noticed is that there's a section about people on the wait list and people that have been transplanted. And basically, if I understand what the letter is saying correctly, is the rules are essentially the same for both groups of people. Would that be a fair statement?
Well, I think that both people in renal failure and patients that are on immunosuppression are in a high risk group. So I think the same precautions apply. And so that's one of the reasons why at present we feel comfortable transplanting people, because dialysis isn't a freebie, and people are dying on dialysis all the time. And so if you're able to transplant people that are at a high risk of maybe, now say you have a 4-year wait and you're 55 years old and you're diabetic and you have some vascular disease, and you may have some coronary artery disease but don't have any stents, maybe in 4 years your risk of dying on dialysis is 15% or something like that. If you have a risk of dying of coronavirus of 3%, or say you're in a higher risk group 5%, you're still 3 times more likely to die on dialysis and have a problem or die with the coronavirus. So those are the patients that we're looking at to try to get transplanted now, that aren't at the top of the list and aren't going to get transplanted in a month if they wait. And it's more in their favor. And a couple of the people that I've transplanted this week, I said, you really hit the lottery. because we're doing this strategy to help people. And you really weren't doing well on dialysis, and you're real high risk. A couple of the people, and so in a lot of ways, this is great for them, because they may not have made it to transplant, but we're trying to make sure that organs aren't going to waste without putting people at significant risk.
Okay, you mentioned the IU virtual health clinic website. Can you tell us a little bit what that's about? How does that work?
Well, the IU has this new app that they provide. It's a virtual visit app that you can download from the App Store at Apple. And so you create a free username and password, and then you can, if you think you've got coronavirus, you can punch in the symptoms. There's a tab in there to look for coronavirus help, and they'll tell you whether or not you need to be tested or where to go. And they'll even set you up for a test. But it's also a way that you can access the healthcare. It doesn't have to be coronavirus; it can be something else, and answer your questions and access, and even get to be seen virtually and stuff like that. So it's kind of neat. I was just playing on it earlier this evening. And it's a way that we access when some patients are not in our hospital. We can access that and talk to people to try to get them transferred and stuff. So it's an access portal for the healthcare system. It's pretty kind of neat.
Another question that's come up: a lot of herbalists are recommending natural products to boost the immune system, but at the same time, people like me, we're taking immunosuppressant. These herbal products, are they helpful? Are they not helpful? Are they things we should stay away from? What's your opinion?
In general, with our transplant patients, we don't recommend herbal products because they can interact with your immunosuppression. And it's a great question because yes, you're on immunosuppression, and we don't necessarily want your immune system to be fantastic immune system to recognize your kidney, yet you don't want to be completely immunosuppressed and then be at more risk for infection. It's a pretty difficult thing. But if you end up taking herbal supplements and you end up having too high a prograph level or too low a prograph level, it can really mess with your overall immune system. And if you're on steady immunosuppression and you're taking your meds and you're getting your labs, then you're going to be at a lower risk than if you're playing around with your immunosuppression. So we don't recommend the herbal supplements in particular, just because it affects immunosuppression and stuff.
Okay.
So I think the biggest thing is take the wash your hands, don't touch your face, and stay away from sick people. I think that's better than herbal supplements.
Take your post-transplant medication and be a good boy and girl, right?
100%. If you take your medicine and get your labs run, you're going to do very well. Where my patients, I have patients that end up losing their kidneys, is because for one reason or another, they either financial or whatever, they weren't taking their medicines, and they end up having low levels, and then their immune system kicks in, and then they end up losing their kidney. Sometimes it's because the doctors are running their medicines too low, and sometimes they're running their medicines too low because they're trying to make their meds last because they don't have enough money to get their meds. Or sometimes people just do stupid things. But if you do take your medicines and get your blood work and make sure everything's okay, your kidney's going to last a long time, long time.
Okay. In the interest of full disclosure and to kind of give a preview, when you did my transplant, you wrote a professional paper about it. Just briefly, can you tell us a little bit about what that was all about?
Sure. So I've been interested in immunology for a long time and doing very high risk immunological patients with positive cross matches. And so I went through the process to be accredited to run an HLA lab. And so during that process, which I've now finished, I needed case reports on how to do it. And yours was a very interesting case report because you had changes in your antibody profile from blood transfusions. And so you had one profile at one point and one at another time. And so when your offer came up, a lot of people shy away from historically positive cross matches, and you had very high levels of antibodies from related to whenever your immune system was provoked by a blood transfusion. And so I said, I think his normal immune system is going to be just fine. And that's not all the high antibody levels were from when he was having blood transfusion. So I thought it would be okay to transplant you after seeing that. And so many people would not have transplanted you.
But you did.
Sometimes I do stupid stuff.
Yeah. Well, Doc,
but you did great, and you've had no issues with antibodies. And so, everybody, you always say, you're a calculated risk, and the doctors do all the calculation, and the patients take all the risk. But really, if you have a good understanding of the immune system and how things are going to react, usually you do very well when you try to help people. So.
Okay, well, April 27th, I celebrate my 4-year anniversary, and I'm very grateful, Dr. Goggins. If I ask you to come back and talk about the paper a little bit more, would that be cool with you? Can we do that?
Sure, if people are interested in stuff like that.
Okay. Steve, do we have any other questions from the audience that we missed? Hello? I'm going to assume we didn't. Okay. Is there anything I have not asked you about with reference to the coronavirus and kidney transplant patients that maybe I should have, that for some reason or other I left out, or issues that you would like a chance to point out?
I think that the questions that you asked were very complete. But I do think that people should particularly transplant patients, should be safe, particularly now that things are getting worse. And that's why I think if wherever people are living, if you want to check out what your county looks like, go to the Johns Hopkins website and you can look and see. And if you're in a higher risk area, that's where you have to take super precautions. You might even have to self-quarantine, stay in your house if it's that bad. If you're over 60 or you have other conditions like that, you're not going to be wanting to go out. But if you're in, say you're 35 years old, otherwise healthy with your transplant, in your low risk area, you can be safe, wash your hands, stay away from sick people. You can wear a mask if you're going to go to an area where there's a lot of people, stuff like that. But be super smart, be safe.
Okay, Doc, a question came in from the audience. Are deceased COVID-19 kidneys good for a transplant, or that's something that you're going to avoid, at least until there's some scientific proof one way or another?
Yeah, I think at present, pretty much everybody's avoiding those organs. If it's found out that it behaves like the common cold, which we don't test for, and it cannot be transmitted through organ donation, then it won't be anything that bothers us. We'll transplant those organs.
Well, Doc, my training is basically as an old trial lawyer, so I was trying not to do a deposition tonight. So,
but that's why your questions were so good.
Yeah. So anyway, I just want to say thank you for coming on and taking so much time with us and being so generous. And I hope to have you back sometime. And God, you were wonderful. I appreciate this so very much.
Well, I hope that the information help people so that people aren't so scared and they have an idea of what they can do. And I think if patients, have more knowledge and they have a better understanding how to protect themselves, they'll do better, and there'll be less. There's so much anxiety right now about this that at least if you have some sense of what you can do, maybe you'll sleep a little bit better at night.
Sleeping would be good, Doc. For those of us that have insomnia, sleeping would be good.
I enjoy it too.
All right. Well, thank you so much for coming on. That pretty much wraps up our show for tonight. We're pushing an hour here. The good doctor's been kind enough to answer questions, and the audience has been participating, and I feel it went very well. Thank you so much, Dr. Goggins, and we will talk to you again sometime in the future.
Okay, Jim, take care. Thanks a lot.
Take care.
Now. Okay.
Bye-bye now.
Okay.
Okay, so I hope that everybody got a little something out of that. Just to summarize from the list that IU Health published, transplant candidate, transplant recipient household members, postpone non-essential travel, minimize exposure in public and crowded places, minimize close contact, practice social distancing 6 feet or more, don't shake hands, cough or sneeze into your tissue or your elbow, throw the tissue away immediately wash your hands, don't touch your face, eyes, nose, mouth, disinfect frequently touched substances like your TV remote control, light switch, cell phone. I'm cleaning off my cell phone 2-3 times a day right at the moment. Increase your ventilation if it's possible in your home. Work from home if it's feasible. Use social media, remote communication for work. Avoid sick people at home or in public. If someone in your house is infected with the COVID-19, have them wear a mask, have them put someplace where they're isolated and we stay in one particular room, have one person act as a caregiver to go in and out to that person. If we follow these general recommendations, that's the best way to minimize the exposure and the spread of COVID-19 among transplant patients and your general population. So at any rate, this is your Uncle Jim. Oh, one more thing. I forgot. One more thing. Stores that are open special hours for seniors. There are some grocery stores, like in my area, Strachan Van Til's, are open between 6 and 7 o'clock. Target for seniors between 8 and 9 in the morning. Walgreens, 9 a.m. to 10 a.m., special hours for senior. Walmart, 6 a.m. to 7 a.m., special hours for seniors. So if you're like me, you're over 60, you're a kidney patient, you're a transplant patient, you're immunely compromised, you might want to take advantage of these situations. That might be the safest time to shop. Oh, next week, we're talking with another great kidney advocate, Melissa Toff. She's going to talk to us about pre-transplant deposits, so be sure to tune in. All right, Steve's telling me I got to sign off, so good night, everybody. Thank you for watching Kidney Stories tonight, and we'll talk to you next week.